We're now slowly coming to understand the physiology of mitral valve closure and also the mechanism of regurgitation. 3D echocardiography was probably the technique which helped most. We now know exactly what the shape of the mitral valve is and how, for example, the leaflets and the annulus moves during systole. But does it matter why the valve is incompetent? Yes, it does. Because based on the mechanism, we also decide the treatment strategy. And the surgeons want to know too. One other thing that I want to mention in this context is a recent publication by a former co-worker of ours, Dr. Dal Bianco, who now works in Boston. And he showed that if you put restriction to a leaflet, in other words, if you tighten the leaflet motion so that it cannot close, and if you put stress on the tendons, then what we see is reactivation of growth, embryonic reactivation. In other words, possibly the mitral valve is able to regenerate. Now, these are very early studies, but it could mean that the mitral valve is capable of regeneration. This opens complete new possibilities for treatments maybe in the future. Keep this in mind when you look at the following chapter. So, it's important to know the mechanism, because it gives us clues as to the etiology of regurgitation. It helps us to assess the prognosis, in particular if regurgitation can be expected to be reversible, how to treat the patients, and finally, if the valve can be repaired, and if yes, how the valve should be repaired. What do we need to know? We need to know all we can about the valve morphology. Is it thickened? Is it myxomatous? Is it sclerotic? Is there maybe annular calcification? What is the extent of involvement? Where is the origin of the regurgitant defect? And why is the valve incompetent in the first place? What is the mechanism? Now I would like to take you back to a how-to session, and I want to show you how we can actually differentiate the different segments of the mitral valve with the help of echocardiography, first with the parasternal approach. So let's see how we can actually differentiate between the individual segments. First of all, with the parasternal approach. If we look at the mitral valve from a parasternal long axis, this is obviously the anterior leaflet and this is the posterior leaflet. But if I tilt the transducer further down, I get to see more of the posterior-medial aspects of both valves, of both leaflets. And if I tilt the transducer upwards, then I see more of the anterolateral portions of the valve. So this is helpful if you want to differentiate where, for example, the origin of a jet is or where the pathology is. You can see that even better in a short axis view. Now this would be the short axis view. We have the opening and closure of the mitral valve. This here is the anterior leaflet and this is the posterior leaflet. And these regions here are the commissures. So you'd have the anterolateral commissure here and the posterior medial commissure here. And you can then differentiate the segments. This would be P1, P2, and P3, while this would be A3, A2, and A1. And if you then put the color in the short axis, you can see where the origin of the jet actually is. So this is now the optimized color view, and you can appreciate that the origin of the jet is from two regions here. This would be in the medial portion of the valve, so 2, A2 or P2, we cannot say from the short axis view, and 1. You can see that clearly here and here. You've seen this diagram already. This is how we segment the mitral valve. Anterior leaflet, posterior leaflet, and the different scallops, anterolateral, medial, and posterior-medial scallops. But which parts of the mitral valve can be seen in the individual views? Well, this diagram should illustrate how we can assess the mitral valve with the different views. Now, it looks a bit crowded, I agree, and in any case, you can also find this diagram in your fact sheets, but I'll slowly go through it and you will see it is not as difficult as it may seem. Let's start with the four-chamber view. The four-chamber view cuts right through the middle of the mitral valve. You would have the anterior leaflet and the posterior leaflet, and you would have the medial parts of both leaflets in your field of view. The two-chamber view is more or less perpendicular to the four-chamber view. So in this view, you cannot really say which valve you are hitting. If you have the transducer tilted more towards the posterior aspects, you have the posterior leaflet. If you tilt them more to the anterior aspects, you have the anterior leaflet. So in the two-chamber view, you cannot really distinguish between anterior and posterior, but you can nicely distinguish between 1, 2, and 3. And in particular, you can see the commissures. So the anterolateral commissure and the posteromedial commissure. That's why the two-chamber view can also be called the commissural view. If you now tilt the transducer more cranially and you hit the aorta, you will have the five-chamber view. In this case, you will see the anterolateral portions of the valve, in other words, A1 and P1. If you tilt the transducer even further cranially and you're almost outside the valve area already, then you will see the anterolateral commissure. In contrast, if you move the transducer more caudally, you will have the region of A3 and P3, so more the posteromedial aspects of the valve. And if you move the transducer even further caudally, you will have the so-called coronary sinus view. Remember, we talked about this view in the How to Image section, where we also see the coronary sinus. And in this view, we can nicely see the posteromedial aspects of the valve, the posteromedial commissure. So just by tilting the transducer from the four-chamber view, either more upwards or downwards, you can kind of scan the entire valve. Now if you rotate the transducer and we come to the apical long axis view, we will also hit parts of the aorta, and we will hit more the anterolateral parts of the anterior leaflet and more the medial parts of the posterior leaflet. So this is what you will see in the three-chamber view or apical long axis view. The following demo will now show you how we can assess the different scallops from an apical approach. We can also differentiate the different segments of the valves from an apical approach. So let's start with the four-chamber view. If you have the four-chamber view, you see the following portions of the valve. You would have P2 and A2. So the medial portions of the valve are visible in the four-chamber view. If I tilt the transducer towards the five-chamber view, I would get the anterolateral portions of the valve, in other words, P1 and A1. If I move towards the coronary sinus, so this is the four-chamber view, and now I'm tilting towards the coronary sinus, I would get just the opposite. I would get the posteromedial portions of the valve. So this would be P3 and A3. You can also use other views, for example, the two-chamber view. This would be a two-chamber view where we cut along the commissural closing line, so you cannot really differentiate between the anterior and the posterior leaflet, but you can say exactly which portion of the valve you see. Here this would be the anterolateral commissure, and this the posteromedial commissure, and this in between would be the medial aspects of the valve. So looking at the morphology, you can see where the problem is located. Even though you cannot say if it's the anterior or the posterior leaflet, you can say if it's further anterolateral, medial, or posteromedial. You can also visualize the different segments with the parasternal, with the apical long axis view. So this is the apical long axis view where you have the posterior leaflet and the anterior leaflet. And in this view, you see P2, sometimes P3, and this would be from the anterior leaflet A1. So these two portions of the valve are also visible in the apical long axis view. Echocardiography and color Doppler not only shows us where the jet came from and how severe regurgitation is, but also what the mechanism of regurgitation is. So the direction of the jet is equally important. The first mechanism I'll discuss is the bileaflet prolapse. Remember, in the chapter on quantification of MR, we already saw an example of a bileaflet prolapse. Well, in bileaflet prolapse, we have symmetry of the valve. Therefore, we have a very central jet. You can appreciate those central jets best in a 4-chamber view, but also, for example, in a 3-chamber view. One thing you have to be aware of is that it always depends on the degree of symmetry between the anterior and the posterior leaflet in which direction the jet will go. Sometimes you will have predominance of the anterior leaflet, sometimes predominance of the posterior leaflet. So the central jet might or could sometimes also diverge more towards the interatrial septum or more towards the lateral wall. But in general, the jet will be more central if the patients have a bileaflet prolapse. And this is an example. We have a mitral valve prolapse with a myxomatous valve. You can see thickening of the valve, and we see prolapse of both leaflets. However, note that the anterior leaflet seems to prolapse a bit more than the posterior leaflet. So the jet is fairly central, but it does diverge a bit more towards lateral. Well, how severe do you think regurgitation is? Let's practice. Remember, in the chapter on quantification of MR, we talked about the problem that we do not always have holosystolic regurgitation. Well, this is such a case. We see that the jet does not begin at the beginning of systole, but probably somewhere towards the middle. So we will probably overestimate the severity of regurgitation if we simply look at one frame. So my guess would be regurgitation is maybe mild to moderate. By the way, it has been my observation that very frequently patients with bileaflet prolapse don't have significant MR, or at least even though they have significant prolapse, regurgitation is not severe. So, as a general rule, and we talked about that already when we discussed flail leaflets, the severity of MR does not always correlate with the severity of morphologic changes. Keep this in mind. But now back to the mechanism, to the prolapse of the posterior leaflet. If we have prolapse of the posterior leaflet, we have a channel which is directed towards the interatrial septum. Therefore, the jet is also directed towards the interatrial septum, so medially, but also anterior. You can appreciate that best in a 4-chamber view and also in an apical or peristernal long axis view. We need to see an example. Prolapse of the posterior leaflet. See how prominent the prolapse actually is. And the jet is directed here towards the interatrial septum. As a matter of fact, you can really see how the interatrial septum bulges to the right because the jet is also directed into the interatrial septum. How severe do you think regurgitation is? Well, I don't think you need PISA quantification here, and you probably do not need volumetric methods or anything else. Just look at it. It's severe. I'm sure you all agree. Again, a pathology of the posterior leaflet, however this time not prolapse but flail. Very similar jet direction. Why? Because again the channel is directed towards the interatrial septum, so medially and anterior. As a matter of fact, the only difference between the prolapse and the flail leaflet is that sometimes you do see more eccentricity in patients who have a flail leaflet. Here's a very nice example. Posterior leaflet which is thickened and ruptured. The direction of the channel is towards anterior, and therefore we also have a jet which is directed anterior. Again, the question, how severe is MR? Severe. I think there is, again, no doubt. A special form of flail leaflet, which is atypical with respect to the direction of the jet, is shown here. Here we have a posterior leaflet which swings completely open. That's why I would also like to call it the saloon door effect. In this case, obviously, the jet is not directed towards the interatrial septum, but the jet is more straight, right, parallel to the lateral wall of the left atrium. You will also see this direction of jet in patients who have papillary muscle rupture. So there too, you do not have eccentricity, but you have just a straight jet, a very broad jet obviously. Here's an example. Posterior jet direction, both in the apical long axis view and also in the peristernal long axis view. How severe do you think regurgitation is? Well, remember, if we look at the jet body itself, we will probably think it's not very severe, but if we concentrate on the proximal portions of the jet as we should, we can appreciate the severity. So again, a severe form of mitral regurgitation. Very similar jet direction if we have a flail anterior leaflet, so lateral and posterior. Here's an example. Flail leaflet of the anterior leaflet. Actually very difficult to diagnose, but we talked about the difficulty and how subtle these changes can be in flail leaflet. And here we have significant regurgitation with a jet that is directed posterior. Commissural prolapse. Usually if we have a commissural prolapse, we have involvement of both the anterior and the posterior leaflet, and the jet direction can vary. It can be more towards the center of the ventricle, but it can also be very parallel to the anterior or to the posterior wall. Now, commissural prolapse forms are very difficult actually to detect because in the standard views we do not usually see the origin of these jets. So you have to use atypical views to demonstrate commissural prolapse forms. Now we'll take a look at a patient with MR and let's see if we can find out where the origin of the jet is together. Let's take a look if we can find the origin of mitral regurgitation in this patient. We'll start with the peristernal long axis view, and we will look at the regurgitant jet, which we can see quite nicely here. It's probably maybe mild to moderate regurgitation, certainly not more. But what I would now do is I will tilt the transducer towards posterior, and while I do so, I will try to see if I can image the proximal portions of the jet, so the origins of the jet. And you can see, I can still see the regurgitant jet here, even in the posterior medial regions of the mitral valve. Okay, now I will move the transducer back, and you see I'm losing the proximal portion. I can still see some jet, but not the origin. And then I will move more cranially, and all of a sudden the entire jet is gone. So from this view, I would have the impression that the origin comes more from the posterior medial aspects of the valve. I can take a further look by using the short axis view. First, I'd have to image the mitral valve so that I can see the anterior and the posterior leaflet. And then I just enter the color and then scan the valve, moving downwards until I see the regurgitant jet. And here it is. And you can see nicely that the origin of the jet here is truly at the posterior medial commissure and not in the remaining portions of the mitral valve. So in summary, this is a maybe mild to moderate regurgitation where the origin is from the posterior medial aspect, so it's a commissural problem of the posterior medial commissure. So here's how you can detect such jets. First of all, use the peristernal short axis views right at the level of the mitral valve, where you can see the anterior leaflet and the posterior leaflet. And these regions, remember, we learned that in the chapter on how to image. These regions here are the commissures. The anterolateral commissure here and the posteromedial commissure here. And here's a very nice example of a jet that originates right here from the commissure, the posterior commissure. Okay, and now take a look at the four-chamber view. The same patient, we tilted the transducer downwards to the coronary sinus view. This is the coronary sinus here. And in this view, we actually see the origin of the jet. When you try to find the origin, always look at the proximal part of the jet and not at the distal part, because this, the proximal part, this is the region where the jet actually originates. A fairly infrequent cause of regurgitation is leaflet perforation. Leaflet perforation usually involves the anterior leaflet, and it is mostly, almost always, a consequence of endocarditis. What you see is a jet that passes right through the mitral valve and since the anterior leaflet is usually involved, a more posterior jet direction. Here's a very nice example. First, take a look at the four-chamber view. In the four-chamber view, we see a destructed and almost aneurysmatic basal portion of the anterior leaflet. And if we take a look at the color, we see that a jet passes right through the anterior leaflet, which is indicative in this case of leaflet perforation. One side comment, why does the patient actually have a perforation? Well, he had endocarditis, but not of the mitral valve, but actually primarily of the aortic valve. And what happened was that infectious material was carried to the anterior leaflet because the patient also has aortic regurgitation, and thereby we had secondary involvement of the anterior leaflet. The patient developed an aneurysm here and a destructed anterior leaflet, and finally the leaflet perforated. In all of the examples I showed you so far, we had some structural problem of the mitral valve. Now I want to show you some secondary causes for mitral regurgitation. The most common cause of secondary MR is annular dilatation. This usually happens in the setting of a dilated left ventricle. In this setting, we have dilatation of the annulus and also a shape change of the annulus actually, which draws the leaflets apart. You will typically find a closure point which is fairly down towards the left atrium and a central jet. This is nicely visible in a four-chamber view, but also a two-chamber view. The specific finding in the two-chamber view, however, is that you often see multiple jets here because we are now cutting the mitral valve exactly parallel to the line of closure, and we have certain areas where there still is coaptation, whereas other areas do not coapt. So we have many multiple jets, or if MR is severe, often one broad jet. Remember, in the two-chamber view, we tend to overestimate the severity of MR because especially in the setting of annular dilatation do we have more oval jets which are broader in the two-chamber view versus the four-chamber view. Look at this four-chamber view of a patient with dilated cardiomyopathy. We have a large left ventricle, we have severely reduced left ventricular function, but note exactly how far down towards the left atrium the line of closure of the mitral valve is. With color Doppler we see that we have a central jet. How severe do you think regurgitation is? I would say it's moderate to severe. Another form of secondary MR is leaflet restriction. First, let's talk about the restriction of both leaflets. You will find this often in combination with annular dilatation in patients who have a dilated left ventricle. What happens in this situation is that we not only have a dilation of the annulus, but also some form of apical or lateral displacement of the papillary muscles, and thereby there is a pull on the leaflets which prevent them from closing. So there's restriction. We can see that in the four-chamber view and also in the three-chamber view. This time we have a point of closure which is more towards the left ventricle versus the patients who have annular dilatation. The direction of the jet, again, is very central. However, the jet direction can vary depending on the pattern of restriction, if the anterior or the posterior leaflet is more involved. Take a look at this example. Again, we have a patient with a dilated left ventricle with highly reduced left ventricular function. But take a look at the mitral valve this time. Now we don't have a line of closure which is far down towards the atrium, but actually fairly far in the left ventricle. Still, we have significant MR, which is actually more than in the previous case, and we have a fairly central jet. So this is a typical pattern of restricted leaflets in combination with annular dilatation with a central jet. Restriction can also only involve one leaflet. More frequently, it is the posterior leaflet, especially in the setting of an inferior infarct. In this case, we have a geometric change of the inferior wall, which kind of displaces the posterior papillary muscle apically and more posterolaterally, and thereby there is a pull on the posterior leaflet which prevents the leaflet from closing, so it can't move freely towards the line of closure.
In this case, what we have is we have a typical position of the posterior leaflet and the anterior leaflet, where the shape is that of a Y. The direction of the jet is lateral and posterior. Actually, it flows right behind or along the atrial vicinity of the posterior leaflet. Another thing that is important to consider, the origin of the jet is fairly far within the left ventricle. Why? Because the line of closure, or the point of closure, is actually fairly far within the left ventricle. Another thing that is important in the setting of a restriction of the posterior leaflet and posterior MI is that in this situation we don't have a very broad line of closure, we only have a point of closure, and therefore there is no compensatory mechanism that can compensate for annual dilatation. So if you have additional annual dilatation, it will strongly affect the degree of mitral regurgitation. This is a perfect example. We have a posterior infarct and a restricted motion of the posterior leaflet. The posterior leaflet can hardly move. And here is the anterior leaflet, and you can see it is only touching the posterior leaflet at one point, and we have the typical Y shape that I mentioned previously. The origin of the jet is far within the left ventricle, and the jet flows right behind the posterior leaflet into the left atrium, posterior jet direction. Again, my question, how severe do you think regurgitation is? Again, very severe, I would say. Don't forget, the area of the jet does not correspond to the severity. We have the Coanda effect, which leads us to underestimation of MR severity. One could actually quantify the degree of restriction by measuring the so-called tented area under the mitral valve leaflet. Now, we don't do this obviously in patients, but it does help you to exemplify or to understand the problem we have in the setting of leaflet restriction. The leaflets are pulled towards the ventricle. The last mechanism of MR I would like to discuss is that of MR in obstructive hypertrophic cardiomyopathy. What happens here? Well, again, the mitral valve is of normal structure, but we do see a shape change of the mitral valve caused by the so-called systolic anterior motion of the mitral valve. Remember, it is the mechanism that drags the anterior leaflet towards the septum by the Venturi phenomenon and other factors. What happens? Well, we have a shape change which opens up a channel where the jet is directed more posterior. Here's an example: hypertrophic cardiomyopathy with turbulent flow in the LVOT, typical SAM, and a regurgitant jet which is directed more posterior. You can see even more eccentric jets in some patients, and you can also see it in a 4-chamber view. So here we have the jet which is directed more laterally. So lateral and posterior jet direction in patients with hypertrophic obstructive cardiomyopathy.
Watch the following demo and you will see how we assess a patient with MR with respect to the mechanism. So the jet direction can give you very valuable information about the mechanism of mitral regurgitation. We'll start with the parasternal approach. When we put the color into the valve, in this case we can see that the jet direction is anterior. Even though we do not see the jet as nicely as we would like to see it, it's apparent that the jet direction is anterior. Okay? It's difficult to quantify regurgitation from a parasternal approach, but the jet direction can be visualized. But let's turn to the apical view now. The apical view, here in the 4-chamber view, immediately shows us that the jet direction is not only anterior, but also medial. So we see the jet going towards the interatrial septum, which also bulges a bit. This again suggests that there's a problem of the posterior leaflet, either a flail leaflet or mitral valve prolapse of the posterior leaflet. The third view that I would recommend is the apical long axis view. And in this view, if we put the color, we again see that the jet is directed anteriorly, so not only medially but also anteriorly, also indicative of a problem of the posterior leaflet. And if you want to see more cases and examples, don't forget to visit our atlas. What else do you need to know? Well, first of all, you do not need to assess the mechanism of MR in patients who have mild or mild to moderate MR because there are no surgical candidates anyway. And what does a surgeon not like? He does not like extensive involvement. In other words, if more than 2 segments are involved or even more. He prefers the posterior to the anterior leaflet if he wants to perform repair. He does not like the commissures as much, and calcification is an absolute enemy to repair of mitral valves. Still, it is always a decision of the surgeon, and with the experience of the surgeon, he will also be able to repair valves which seem very difficult to repair. And I've seen fantastic results even in patients who had terrible valves. So you see how powerful actually transthoracic echocardiography is. In most cases, we do not need TE. In 80 to 85% of patients, I would say transthoracic echo is enough. Well, now we talked about the severity of MR, the cause of MR, the mechanism of MR, the hemodynamics. The only thing that is still left is what do we do with the patients if we finally make the diagnosis? How do we treat them? What are the indications for surgery? This will be the issue of the next chapter.